All right. Welcome, everyone, and hello. My name is Hannah here at ARC, and we are going to be learning about myofunctional therapy from Anna Housman. Anna is a speech language therapist and orofacial myologist, currently working at Emerge Pediatric Therapy Clinic since 2015 in Durham, North Carolina. Prior to that, she worked in the public school system for a year and a half, and the bulk of Anna's career has been spent focused on working in conjunction with the OTs to understand the sensory systems and how to integrate them into speech therapy. So we're really excited to have her here today, and I'm just gonna go ahead and send it off to Anna to start her presentation today.
Thank you so much. And I am blown away by how many people are here to hear me talk. I appreciate everybody showing up and having questions and being ready to learn more about orofacial myofunctional therapy, along with all of the wonderful tools that I'm obsessed with from ARC. So yeah, as I was talking with Hannah, we were discussing how orofacial myofunctional therapy, or OMT for short, is kind of an unknown for a lot of people. And to be honest, was not something that I really knew about up until probably around the time of COVID, is when I kind of started diving in and started my certification process. And once I saw it, I couldn't unsee it. And so it's now become this passion of mine and kind of where my career will kind of continue on and take me from there, because it's just fascinating. It feels like it's the building blocks for so many things that before left me with questions of why, my clients couldn't make progress or why we were stuck in certain places. And as Hannah mentioned, I work really closely with occupational therapists. So seeing how sensory regulation and the whole body kind of get incorporated into this field is really right up my alley. So let me give you a quick kind of definition of what an OMD, so an orofacial myofunctional disorder, is, and then we can kind of talk about what the therapy is, who's involved in that therapy, and then I'll show off some of my favorite tools. So an OMD is kind of a blanket term. It's how I think of it. It covers a variety of different disorders, dysfunctions, things like that in the face. They are things that impact not only the function, but also the structure of our face. And that includes like how our jaw moves, our tongue, our teeth, our lips. It includes breathing. So usually when I am describing an OMD in a report, like an evaluation, I'll say my client has orofacial myofunctional disorders characterized by, and then list all of these places, because again, it's a big blanket term. So OMDs can impact breastfeeding. They can impact how you chew, how you swallow, how you drink. It can have a big impact on your articulation, so how your sounds are pronounced. It can impact your occlusion or your dentition, so how your bite functions, but also like overall oral hygiene. Do you have lots of cavities? Are there like instances of teeth grinding or clenching? OMDs can include the TMJ, that temporal mandibular joint, TMJ pain. The biggest one that is one of my sub passion areas is sleep. It's something that parents are always floored by, but having an OMD can impact how you sleep, which can then impact how your brain functions and learns. And it's fascinating that that becomes like one of my biggest red flags and indicators that a kid might need this type of therapy is how well or how poorly they're sleeping. It can also impact general breathing, which if your breathing is not as it should be, you're not nasal breathing, you're breathing through your mouth, it opens you up to a whole slew of additional problems ranging from how your immune system, how often you get colds, ear infections, all sorts of things like that. And OMDs can also impact how your face looks. It's kind of a hard line to kind of cross with parents. In my assessments, I do a lot of facial analysis and I end up having to tell parents, yeah, your kid's face is asymmetrical or it's presenting really long. And it's not that I'm being vain, it's that our bones and muscles all have different forces that impact on each other to create a somewhat ideal face shape. And when we see these asymmetries or differences, they kind of point to where we might have an issue. So it's a very complex set of disorders and people can kind of specialize in very small portions of it. But as far as like who often treats in this area, primarily what I've personally seen are speech therapists along with dental hygienists. The dentistry world out there, they're like some of my best friends right now and who I contact and talk to the most. Additionally, on this like team and scope of people that kind of fall within the OMD world, we have lots of body workers often. And that is another blanket term that I'll say. That can include PT, OT, so that's physical therapy, occupational therapy, sometimes massage therapist, craniosacral therapist. I'm sure that I'm missing more. I commonly work with occupational and physical therapists, and there are also ENTs, which in my region of the world are a little bit harder to get on board. Although I have seen on some of the groups and chats that I belong to really wonderful involvement and engagement from ENTs. So it all also depends highly on where you live and the medical community around you as to who can help support you and be part of this team, because it's very rare that we find that OMDs can just be addressed successfully by one person. I can recognize lots and lots of troubles and make really good referrals, but at the end of the day, I'm not an ENT and I'm not an OT. I can only treat and diagnose within my scope. So what you'll hear from me is going to vary from what your dental hygienist can do, is going to vary from what your ENT is going to do, is going to be different from what your body worker is going to do. So yes, I am seeing too in the chat that we've got some people in the dental field. We're starting to look closely at child development, sleep, airway. I love hearing that because it's taking a long time for all of these professions to catch up. OMDs have been kind of like a hot topic where we swing wildly in one direction to the other. Your grandparent, my grandparents, great grandparents were probably in an era where everybody got their tongue tie released and everybody got snipped. And then the medical community kind of swung the other way and said, this isn't necessary. No one's going to have it done. That's a myth. There's no research. And we're now kind of at this place of trying to find balance, that there is a time and a place for this type of therapy. There is a time and place for tongue tie and lip tie releases, but we have to have functional impact. And that was the piece that was missing previously when it was like, everybody gets their tongue tie released. We weren't considering, is there a functional deficit? Because you can have, and we all do have these, they're called frenula under the tongue, the lip, and actually in the cheeks. We all have them. Do you have a functional deficit? And that's where your team comes in to really assess and decide, is this a functional deficit? Can therapy alone fix it? Do we need other interventions? Do we need orthodontics? Do we need surgery? What else? And so the more and more that we dive into this, we're finding people across fields really starting to specialize and look at the whole child. So not just speech therapists, but dental providers as well, looking at airway. We call it airway centric. So finding those dental hygienists, finding the ENTs who are, it seems silly to say an airway centric ENT. You would think that would be kind of automatically in their scope, but not always. So looking at, can we all be looking at how the airway functions and how these muscles function and impact one another? So I really could talk about that all day. My team is probably very tired of hearing me talk about that here. So I'm going to try and like moderate how much on my soapbox I get versus talking and showing you some of the products and things that I use as well. So I, as a speech therapist, like to treat the whole child. And that means that I'm not just going to look and take a measurement under the tongue and say, yes, here's a restrictive oral tissue or a tethered oral tissue. So sometimes you'll see people refer to it as TOTS, TOTS, tethered oral tissues. I'm not just going to look at that and say, yeah, here it is. Let's go and have it released or revised or cut. I start all of my assessments looking literally at the entire body, at posture, the frenulum under your tongue. This is like my favorite fact, and it blows everybody's mind if they haven't heard it before. The tissue under your tongue, the frenulum, is called, it's fascia. So it's this kind of like sticky, stretchy, super thin glue that holds like a lot of our muscles and structures in place. It's very bizarre if you Google it and like look at when people pull like skin and muscle apart, and you can see this like spider web kind of effect of fascia. So that fascia goes from your tongue down your neck, down your shoulders, through your hips, wraps around your knees, and connects at your heels. So restrictive oral tissue in your mouth can impact your spine. It can impact overall posture. It can create hip pain, shoulder pain, back pain. It can change the way that you walk. It can change the comfort and how you sit. I myself had a tongue tie that I recently had released. I went my whole life being fine with no functional deficits until after my first child was born, and had this shoulder pain that wouldn't go away. Uncovered through my profession, I had a tongue tie, had that released, and suddenly was able to use all of the exercises for my chiropractor and see improvement because I didn't have this restrictive tissue impacting my body. So I start with the posture, and then from there we go face, and we kind of slowly zoom into a closer and closer picture. I want to see how the jaw functions. So I'm often looking at, when a child talks, is their jaw moving in unexpected patterns? If I ask them to do something non-speech related, are they able to do something like move their tongue separate from their jaw? That's really important for eating, super important for articulation. How does it move? Is it set far forward? Is it recessed? All of these things can tell me what kind of structural deficits we might have. It may lead me to thinking more about releasing a tongue tie, but whether or not a tie is there, what I do consider is how can we strengthen and start to help that jaw move in an appropriate way, decrease any pain that we might be feeling, and also add stability for tongue movements. So one of my like favorite tools are bite blocks. I love these from ARC. There's a bunch of different kinds out there in the world, but I like, there are Y ones, and then there's also like a standard straight one. I like them both for different reasons. They come graded. I have a colleague who likes to start in the opposite direction that I do. I like to start at the smallest level. And so then I'm just working on like having my kids bite on the side, and I'm gently pulling, and you'd be amazed at how many kids can't maintain a bite with any kind of pressure. They immediately lose it. And so we'll start there with just building up basic strength so that the next exercise that I layer on top, they have more success with. If I'm asking them to elevate their tongue to behind their front teeth, but they have trouble holding their jaw still, their jaw is going all over the place, the tongue's having a hard time. So I like to start with building basic stability and then moving on. And as they get to bigger and bigger blocks, then we can start incorporating exercises like, can you hold your bite block? And now let's introduce elevating our tongue. And so before, when a kid was groping, now they have like an extra kind of support to lean on while working on that other muscle. Their brain can kind of focus on one thing at a time rather than, okay, I got to keep my jaw still and my tongue has to move and I still need to breathe and think about all of these other activities. A caveat that I'll probably say a couple of times throughout this is these are exercises that I prescribe to my clients based on deficit. So if you're a parent out there in the world, I would recommend seeking input from a therapist before just starting random exercises that I'm going to present to you, because you want to make sure that you're targeting the correct muscles in an order that makes sense and in a way that is going to support the goal that you're seeking. And it can be hard to really look at a kid's mouth and say, oh, their jaw is moving kind of funny. Well, why is that? It may be that these don't help them. They need something different. So these are exercises out there that I use and love and how I do them, but I'm not able to give you the clinical reasoning behind it to help you decide if that's right for your child. But anyways, moving on. Some other exercises that I like to do regarding the jaw. These have quickly become some of my favorites. They're the hollow bite tubes, and they are, if you can't see on here, but if you were in person, you could see that they're like 1, 2, they're labeled size 1 and size 2 on each one, and they get incrementally more difficult. They're like firmer. So I use these a lot, again, to build up strength and coordination. A lot of times the kiddos that I see have trouble coordinating chewing. And when they are chewing, their tongue isn't lateralizing. So I will often take a tube, and I start light and build up to the blue, but I'll take a tube and hold it to the side and work with the kid on taking really big bites. Lots of kids who have tethered oral tissues, they munch and they take tiny bites in the front because their tongue's not moving food to the back. They're not used to chewing on back molars, or food gets stuck back there, or food's all over their mouth, because ideally when we're chewing and eating, we have our cheek. And if the muscles in our cheek are working well and our tongue is working well, they keep the food central on our bite surface. So actually I have a giant mouth. So if we have our cheek here and your tongue on this side, we're trying to keep food on this bite surface. And kids who have OMDs oftentimes are either pocketing food because their cheek muscles are weak, or their tongue isn't lateralizing, so it's not pushing the food onto the surface. Food winds up everywhere. So it's part jaw, part tongue, part cheek. But instead of chewing this way, where the bite tube kind of stays directly on my teeth, I like to turn it this way because it starts to touch and push against my tongue. And so as I'm chewing, my tongue's naturally kind of trying to work out and figure out, why is this blue thing now, in my space? So the tongue starts to kind of push back against it, and we get to work on a couple of things all at once. And I find that too, I inadvertently kind of learned that they make like a sound when the kids bite and make the pieces touch. And some of my kiddos have really found that sound to be funny and motivating to use it. Additionally, I love that they're hollow because I'll dip them in food. So I have kids who are not able to take on a full spoon, but we can explore food and start introducing it into a chewing exercise without having an entire spoonful of applesauce or something to manage. So I love the hollowness for that as opposed to the solid. I have a little more flexibility in what I can do. Let's see, other tools that I really love. So in my assessments, again, I'm looking at the jaw, and then I might kind of narrow in on the lips and how they work. If we have weak lip muscles, we'll see things like water spilling out when they're drinking, or food collecting at the corners of their mouth. Or we'll see like super tight tension in their face muscles. The mentalis muscle is right here on your chin, and we'll often see bumps kind of arise there, where kids really having to overactivate muscles in order to keep food in. I have had kids who grind their teeth, and that's come from lip instability because they're overactivating all of these muscles, and it's leading them to clench to be able to close. So some of the things that I work on in regards to kind of organizing coordination of the lip muscles, and also just general lip closure, would be our button pulls. So when I learned about button pulls, they were demonstrated to me with like actual buttons and thread. And I don't love that because I don't like damp, wet thread. And that's what happens to thread when you A, put it in a kid's mouth, and then B, wash and sanitize it. So for my clinic use, where I'm doing this all day long, when I saw ARC's buttons for the Z Vibe, I was like, sold. I want every size. Everyone on my team has them because I don't like damp thread around in our toolkits. So I like the handle. It looks fun. Kids love my Z Vibe, which is what this purple thing is. You can turn it on and get vibration. So occasionally for my kids who really have like trouble sensing things that are in their mouth, the vibration's helpful. I always start with the biggest because it's the easiest, and then you work your way down to the smallest. So we will work on teeth being closed and lips wrapped around. And the goal is, without suction or sucking in on the button, can they keep the button in their mouth while I give gentle resistance? So building up coordination of all of these muscles, and working against resistance. So that's how I use those. And for some of my kids, that's not necessary. Again, having a therapist on hand to tell you what your child's deficit is helpful, because I have some kids who have so much tension that then working on a button pull is going to create even more. But these are great for my kids who have trouble with drinking from a straw, and things like that. Another one of my favorites is, I like the one that's textured, but someone has stolen that out of my kit. So I have my smooth one here. Again, sometimes I'll use this without the handle, but if I have a kid who needs the extra sensation to stay alert in a task, I'll use a tongue depressor and actually have them hold it against their lips, no teeth involved, to again work on lip closure without facial muscle activation. And then I can address nasal breathing. Additionally, I can use it to help kind of train resistance and muscle activation of very specific muscles by pressing downwards, upwards in the front, in the corners, while the lips are closed. So I'll say for some of my friends who don't quite fully grasp what we're doing because of cognitive deficits, well, I will just work on, we're going to blow really big kisses. We're going to go, mwah. And can you keep your lips closed until the tongue depressor, don't let the kiss go until the tongue depressor is gone. So I'll use those sometimes. And you'll hear me say to get towards nasal breathing. That's our kind of ideal rest posture. Whew, looking at my time, I'm telling you guys, I could talk about this all day long. Some other tools that I really like. This is one of my favorites. It's the tongue tip tool. I find that it's really helpful for my kids who need a visual target. I'll set them up in front of a mirror. So now we'll work on the tongue. They've reached jaw stability. So can you keep your jaw open and direct your tongue into this hole? And can they follow it? Could they slide it across this top here? It gives nice tactile input, gives them a visual to aim for while we're working on really skilled fine movements for the tongue. And in addition to that, part two, I would love to do a part two for all of this. I am going to be out on maternity leave, so it might be a couple of months before we can schedule that again. But I also love the probe, which is just like your classic Z-Vibe tip. And I will use that to stimulate the sides of the tongue. If they're not moving, we need the sides of our tongue to lift to make S. Our kids who are lateral lispers, sides of their tongues aren't going up. So sometimes just stimulating the side of the tongue with the probe turned on with the vibration is enough to help them realize, oh, that part of my tongue's got to work. And then let's see, some of my other favorites. I talked about the bite tubes. I have my chewies. I use these kind of interchangeably with the bite tubes. It just depends on the kid. But my last ones that I'll kind of leave you with would be the honey bear cup. I use this every single day. In an evaluation, I leave the straw long to see, and I can kind of judge, are we pulling water independently or not? And then if they are, but they're taking in a huge portion of the straw, I will add in a lip block. I have quite a few at the clinic. This is my favorite one. I joke with my kids that, I'm here to torture you, so prepare yourself. And they always think that's so funny. I'm like, this is torture, right? It's teeny tiny. This is the hardest one. And then they love when they are able to use it. You have to have a certain kid who can enjoy that kind of humor. But what the lip block does is it keeps kids from being able to put the whole straw in their mouth and stabilize with anything other than their lips. So they really have to have good lip activation to get this. So I use this in therapy and pop it into my straw. And again, I like to keep it long so that I can see where the water is coming from. But as they go home and they'll take a honey bear cup home with them, I'll instruct parents to make that straw really, really short. So I love the option of, you can have the tool if you want the tool, but also here's a modification, is making that really short. And then they have to get that same lip rounding and lip closure. My other favorite part about the honey bear is if you take the one-way valve out and you squeeze it, I can control when water comes out. So I have kids working on all the steps to prep for straw cups, but they're not ready to pull water independently. And I can squeeze and control the water and help it go in without like needing to do a funky straw trick where I put a straw in water and cover it with my finger and then release it. I like not having to touch a kid's straw. So those are my quick and dirty like tips and tools that I like. Looking at our time, I want to make sure that we have time to answer questions. And I saw in the chat, as an SLP interested in getting training, I recommend looking at the IAOM, the International Orofacial Myofunctional Association. That's where I'm getting my training through my certification process. Other continuing education that's been super helpful are the Breathe Institute with Chelsea Pinto and Dr. Zaghi, and Deborah Beckman's course have been phenomenal, but there are tons and tons out there. The straw that you can use with one way, so the Honey Bear cup actually comes with this like soft tubing straw, and it comes with the one-way valve that pops in for it. Nicole was saying that she found that the one-way valve is really challenging to use. And I have to admit, I almost never use it, but I do say to my parents who buy it, if your child is ready for it and they can do it, you have the option of like a therapist approved cup that's not a sippy cup that won't spill if you keep the valve in. So I usually only have that caveat for parents who are looking for a cup for at home, and we're trying to find a like happy medium between they want to use a sippy cup, I don't want them to use a sippy cup. So yeah, do I use these tools with in-person therapy or any virtual? I do both. Usually with my virtual therapy, we work with what the kids have at home. Although I've started, since I have been working with and loving ARC so much, we've started putting together kits that our families can purchase and then take away with them. Should they need to do virtual therapy, then they have the tools at home and we can work together that way. And then Hannah, I want to check in with you. I can keep going on the chat, or
no, thank you. Yeah, that was wonderful. I wish we could have this longer, have a part 2. But yes, there was a few questions that I did want to just kind of get in before we run out of time. And thank you for answering some of those that came through the chat. So at what age can a child start myofunctional therapy?
That's a great one. So we usually say that you need to be a very mature 4-year-old. 5 is kind of like the sweet spot for being able to sit and understand that I'm asking you to do these specific movements. That being said, between 2 and 4, you can do therapy that is informed by orofacial myofunctional therapy, but it is primarily feeding based. So it's taking the same kind of concepts, but working with food rather than just with these exercises.
Okay. Let's see. One is from Vandana. How best can we test for a tongue tie? Let's see. I believe so. If like kiddo has severe apraxia and very restricted tongue movements, how best can you test for that for a tongue tie?
Ooh, that's a hard one. There is a thought out there in the world. I heard it from Linda D'Onofrio, who's a speech therapist and highly kind of valued in the OMD world, who says that she will not diagnose any child with any neurological disorder such as apraxia until OMD has been fully ruled out. But those kids who you have suspected apraxia and you need to do tongue tie can be a real challenge. And there's unfortunately like no one specific way. It's looking at the whole child's function. It's watching them eat, watching them drink. If you're able to get under the tongue to do an assessment, there are a couple out there. There's the quick tongue tie tool. There's the tap that I'm not going to baby brain, not going to be able to remember all of them, but there's a bunch out there. But if you're looking at it and you haven't taken coursework in TOTS, you aren't really able to diagnose a tongue tie. And I would urge you to not. I would say instead, you could say, I suspect it and I see XYZ that is pointing that way. Their feeding's disordered, they have limited tongue movement. But then it's a question of functional impact and the ability to complete therapy. It all kind of gets considered in whether or not we then release it. Do we do therapy first? How do we balance that out? So it's a much more complicated question than I could
Yeah.
answer.
No, thank you. And then let's see. So what is the treatment modality to look for in myofunctional therapy? How best can someone find a good local provider? Is there a directory of providers to look for?
So usually Google is your best friend in searching orofacial myofunctional therapist near me. The people who are trained in it usually have it marketed on their website as such. There are also directories, the IAOM, and there's the Academy of Orofacial, the AOMT. They both have directories listed. Oftentimes too, like the Breathe Institute will have people listed as Breathe ambassadors, and those people are often trained and well-versed in OMDs. But Google is probably your best bet.
Yeah. So do you need a doctor's order before seeing a myofunctional therapist?
I do not.
Okay.
Most of the time. I should say most of the time. So at least in North Carolina here, and the way that we do things, I do not need a doctor's referral if you are a private pay client. Here in our clinic, we treat kids who are like cash pay. We also treat some children who have like your major medical, and their families will submit and we help them file, but they're not usually covered under us. Those are also clients who, if they want to come in, that's great. My kiddos who have Medicaid or one of the managed care plans, those do require a referral or a script. But it's not usually very difficult to get. And most of the time, it's fairly easy to at least get the evaluation in. On occasion, we've had some pushback from those insurance providers about whether or not they'll approve therapy, but we've gotten pretty good at arguing our case.
Okay, awesome. We'll try to get through one more. I know it's 12:41. There's been wonderful questions that came through. Let's see. Is it ever too late to start myofunctional therapy?
No, it's never too late. As somebody who had a tongue tie release and did myofunctional therapy at 33, no, it is never too late. I worked with recently, I don't normally see adults. It was a friend's mom. She started at like 65. And it was really, really encouraging because she said for the last 20 years, she'd had major TMJ pain and all these other things and had been dismissed by everybody. And we, in conjunction with PT, she and I were able to get to a point where when we checked her pain scale one day, she said, I can't rate it for you because it's the first time in 20 years I haven't been in pain.
Wow.
So never too late.
Yeah. That's awesome. Thank you so much for your expertise and everything. Is there anything else that you wanted to add before we go?
Oh, I'm afraid if you got me started again that I would miss I have a client coming in at 1:00. So I will hold it from there, but thank you so much for having me. And I was so happy to give all this information. I wish I had time to answer everybody's questions.
No, it's been an honor. And thank you everyone that attended, and thank you, Anna, and good luck with everything. And we hope everyone learned something new, and we'll see everyone next time. All right, bye.